Now let's start with the final section of our lecture, Premalignant Diseases. In this we will talk about the endometrial lesions or premalignant endometrial lesions that can lead to endometrial malignancy or cancer. We will talk about what's the histology of the different premalignant endometrial lesion and what's the management of the premalignant endometrial lesion. Endometrium, by now all of you know what endometrium is. Endometrium is the inner lining of the uterine cavity. Endometrium goes through regular cyclic changes, different changes depending on the hormone levels of the female cycle or during pregnancy or at the time of menarche or at the time of menopause. So very, very important changes that occur in the endometrium. So premalignant endometrial lesion is usually due to long-term unopposed estrogen, particularly around the time of menopause, leads to various type of endometrial hyperplasia. Estrogen is a hormone produced by the ovaries, and it's a very, very important hormone of female reproductive system. And estrogen leads to proliferative changes in the endometrium. And if it's unopposed by progesterone, which brings about secretory changes in the endometrium, then the endometrium keeps on proliferating and it leads to hyperplasia. So it's common around the menopause because now the normal regular monthly cycles are stopped and the estrogen level is unopposed by the progesterone level. So long-term unopposed estrogen leads to endometrial hyperplasia. Risk factors are unopposed estrogen stimulation, if there is delayed menopause, if there is diabetes. PCOS is polycystic ovarian syndrome. Polycystic ovarian syndrome is a disease of the ovaries in which multiple cysts are formed in the ovaries and ovulation is disturbed or ovulation is not occurring. So there is also high levels of estrogen in polycystic ovarian syndrome. And then obesity, again the effect of obese people, usually they have not regular frequent ovulation that can cause endometrial hyperplasia also. So these are some common risk factors for the development of endometrial hyperplasia. Then some protective factors also, nulliparity. Nulliparity is another. Last is a condition in which no pregnancy or the female who never get pregnant is nulliparity. Hypertension. Hypertension is high blood pressure that can also lead to endometrial hyperplasia. Then some protective factors are multiparity, like nulliparity can lead to endometrial hyperplasia. Nulliparity, women who never get pregnant, who never give birth. So nulliparity is a risk factor. So as compared to that, multiparity or who have multiple births, give rise to multiple births, it's a protective factor. It protects against the endometrial hyperplasia. Also normal weight and use of combined oral contraceptive pills. Progestogen therapy. Progestogen therapy now it can affect the unopposed estrogen, which cause the endometrial hyperplasia. So if progesterone is given, it avoid that endometrial hyperplasia. Then menopause. after 49 years of age, that also is a protective factor. Then histology of endometrial hyperplasia or premalignant changes is usually there is simple hyperplasia, or it can be a complex hyperplasia, atypical, when lot of atypical cells are present, or it can be carcinoma in situ. This is the diagram that shows complex endometrial hyperplasia with nuclear stratification and atypia. So this is complex type, not simple, of endometrial hyperplasia. Or it can be carcinoma in situ. Carcinoma situ is the cancer that's is present in the site of origin. Then the management is preventive treatment includes maintain ideal body weight, because patients who are obese, they have higher chance to get endometrial hyperplasia. Then estrogen use in non-hysterectomized women should be restricted. Periodic endometrial sampling, especially after menopause, if there is bleeding per vagina, usually it's because of endometrial hyperplasia. Sampling is important to rule out if there is any malignancy or not. The definitive treatment is if there is a patient who is young with cyst or adenomatous hyperplasia, then cyclic progesterone is given, then induction of ovulation, atypical hyperplasia. If patient is perimenopausal or postmenopausal, then the treatment is different. If it's a hyperplasia without atypia, then moderate to severe atypical hyperplasia. So depending on what are the ages of the patient, treatment depends on that, whether the age of menopause is reached or if the patient is in the reproductive age. Treatment options are different in both conditions. So that was all about our lecture topic, premalignant diseases, in which we talked about different intraepithelial neoplasias, their causative agents, pathology, pathogenesis, and how they are treated and managed. Thank you for watching sqadia.com.